We use, in a traditional acute care model, we use a lot of medical metaphors, agreed? We spend a lot of time talking to clients about their disease, their illness. We use a lot of medical model kind of language. So tell me this. How much time do clients spend with physicians and nurses in addiction treatment in the United States as part of their treatment? No, I mean face-to-face. If this is in fact this kind of significant medical psychiatric illness, how much time do staff spend with healthcare professionals by way of physicians, physicians' assistants, nurses, clients? Yeah, once there's been a sign-off. I mean, we're really using medical staff as gatekeepers around payment approvals and levels of care placement, as opposed to what? So let's be really honest. Apart from processing and payment, physicians don't have a significant role in most addiction treatment programs in the United States, particularly in the public sector at this point in time. And nurses are having less and less, if you really look at how that's unfolded over 40 years. So what do we do with that? Well, recovery management starts with this assumption. It says every person in long-term recovery needs a relationship with a primary care physician. Crucial. Needs a long-term relationship with the primary care physician. Just like anybody with any chronic disorder needs what? Needs that kind of relationship with continuity of contact over time. They know you, they're your partnership, they're your partner and consultant in the management of this disorder. So what we're getting is, within the recovery management model, we're trying to experiment with bringing primary health care clinics into addiction treatment programs. We're trying to work with medical schools. We're trying to work with, what about our clients who don't have any primary health care? Don't have any primary physicians? What we're saying is if you're thinking about long-term management, I'm going to talk to you this later this afternoon about recovery checkups as a formal mechanism over that 5 years that we talked about earlier today. One of the people who has a critical role in that recovery checkup process is the primary care physician. Even if the client disengages from us, that primary care physician, if they've got a good alignment with that client, may still be significantly involved, can do the recovery checkups, and when needed, get that person back to us for support. Next issue around service team. Yes?
But most of the time, physicians are the hardest ones to get over to that model.
You got to train them. The issue is not getting somebody just because they got an MD after their name. What do we have? The issue, I should have been more explicit. Every person in long-term recovery needs a primary care physician schooled to understand something about the processes and stages of long-term addiction recovery. Is that better? Yeah. So that really says we have some responsibilities not only to recruit those physicians, but also to be involved in creating training resources for them.
Just a question. I guess the question is, primary care physician, as relates to the team approach, should be part of the clinical team. But because of dichotomy, because of professionalism, there's sometimes a bit of separatism. I'm using that very mildly.
Yeah.
So therefore, therefore, you have this higher echelon of staff who feels that they're separate, but you need to be involved.
Yeah, the point you're raising is an excellent one around how do we integrate then, if we bring this primary physician in or these nurses in, how do we then really begin to integrate them into the team and do that over time? And again, two things are happening. With the primary health care clinics, we're bringing the clinics in, so we're actually bringing primary medical services into the, if you're dealing with a client group with high co-occurring disorders such as hepatitis C, HIV and AIDS, multiple other complicated acute and chronic medical conditions, what more appropriate place to put a clinic initially to engage and stabilize those than right in the addiction treatment setting? The second thing is there any reason why we couldn't have addiction professionals actually working part-time within offices of primary care physicians throughout the United States? That if in fact, remember I want to go back to our screening, right, when we talk about how do we do this early identification? If every annual physical in the United States included an alcohol and drug screening question that takes about 5 to 6 minutes. And if there were any kind of risk factors raised in that interview, the physician referred to the counselor that works part-time aligned with their primary care office, right? So we got both, we're bringing the physicians towards us, but I'm also saying there's another role in recovery management of us moving towards and actually beginning to provide offices or services in primary healthcare settings.